Right, good morning, everybody. It's 7 o'clock. Not going to wait for more people to join. There's been quite a big group join this morning. I would like to welcome back Lizelle Oosthuizen and Antoinette, who are two experts in the management of ECMO, and Antoinette being a nursing sister with interest in, well, qualification in ICU and who's moved on to the ECMO environment. And then Lizelle being a, what do you call them? They work in theatre. Lizelle, help me out.
Perfusionist.
A perfusionist. That's what she is, but she's no longer she's still a perfusionist. And she's also very, very, very knowledgeable. What's also important about these two ladies is that they're available on the phone almost 24 hours a day, in fact, 24 hours a day, so that if you are battling or transporting or don't understand, they really are amazing. They're even prepared to go with you. So let's, without further ado, start with your lecture, your second one for today. Thank you, ladies. I appreciate the dedication to the training of paramedics, doctors, and nurses.
A huge pleasure.
Thank you so much. Good morning, Mandy, and everyone else. Yeah, this is our passion. So good morning to everyone. We're going to talk about the ECMO modalities and cannulation strategies. Last week, we did most of the VV and the VA ECMO explanation. So we're just going to see if you understood a little bit. So we're going to go to the first slide. And the agenda for today is just to recap the modalities that we've touched on. So it's the VV and the VA modalities, and in different cannulation strategies and cannulas and sizing, and how you will figure that out, and insertion process, and what you need to do a cannulation and how cannulation takes place. In the workshops that we're going to do afterwards, we'll go more into the hands-on things. Okay, so we want you to be interactive with us today. So if you look at this picture, what do you see? Is it VV or VA ECMO? Who would like to take a chance? Anyone? Can you see the picture? So we drain from the inferior vena cava. Our little pump is pulling it out. It goes through the membrane, and then we replace it back into via the femoral artery into the aorta. So this would be VA ECMO. Okay. So
Antoinette, I'm not sure they can unmute themselves. Bonnie, won't you try and unmute yourself? If you can't, if you can just type that you can't unmute yourself. Oh, she can.
Yeah, I did.
Okay, so you are able to unmute yourself to interact, eh? There you go. Antoinette, carry on.
Okay, perfect. So you understand this. So we are draining from the inferior vena cava, as you can see there, and then it goes back into the aorta. So this would be VA ECMO, and then at the bottom part there, you can actually see the distal perfusion cannula connected to the patient as well. So this is very specific in VA ECMO, and it's mandatory that you have a distal perfusion cannula, and we will go into that as we go along this morning. And can anyone tell me what the indications would be for VA ECMO? Just one or two, or how you understand it? Is it for lungs and heart, or only lungs? Anyone who wants to take a chance?
You can even type, people.
It's for lungs and heart.
That's perfect. Okay, so which conditions would this apply to? So it would be for any kinds of shock, septic shock, cardiogenic shock, hypovolemic shock, anywhere where you've got a cardiac output problem. We'll put the patients on VA ECMO, and then it would be blood flow related. So it's not gas flow related, it would be blood flow related, and it will take care of part of the circulation. So if you look at the second slide, you will see that we're busy with the other one. So this is VA ECMO. oh, sorry, VV ECMO. So you can see we drain from the inferior vena cava at the bottom there, and then it goes through the pumpy to the membrane, and then it gets oxygenated. We get rid of the CO2, and then the oxygenated blood will be reinserted into the patient by the internal jugular into the superior vena cava. So this is VV ECMO. And for which cases do we use this? Lungs or lungs and heart?
Usually just lungs.
That's perfect. So you have to have a perfectly functioning heart to be able to go on to VV ECMO. And the patients that we'll put on would be patients like in our situation at the moment, the COVID patients are running high. So we'll put COVID patients on H1N1, pneumonia, all kinds of places where you've got ARDS going on. Okay, so we'll go to the next slide, and then we will go into the advantages of VA and VV ECMO predominantly. Okay, so VA ECMO is to rest both the heart and the lungs. The patient is protected from cardiac arrest, and potential full support 100% dependent on the pump flow if good venous return. So we really need to have the patient on VA ECMO if his heart is not working, so that we can support all the oxygenation in the aorta, where it sends off to all the vital organs. So we need to replace those oxygens into the organs so that they are fully, they can fully function, and we don't have any organ death. Then easier volume management. Yeah. Okay, so in VV ECMO, it's mainly respiratory support, patient's own cardiac output with pulsatility, and that's why I said the heart must be fully functional. Oxygenated blood directly into the lungs, so we don't make use of the inspiration anymore, so we bypass that. So we already inspiratory around the alveoli. Can you hear? Okay. Then potentially more oxygen to the blood. Okay, so if we go to the next slide, this is just a recap. Then the disadvantages of VA and VV ECMO. So on VA ECMO, you have potentially less pulsatility, okay, because your heart's not pumping properly. And sometimes it requires a second arterial cannula for more support. So when you reduce your flow as your patient's native heart's getting better, you might end up with a situation where your lungs still need some support. So then we will actually go over to VAV ECMO. We will cut into the return line, put another line in, and connect that to the internal jugular that goes into the superior vena cava, and then we oxygenate the lungs further there until you are ready to come off ECMO. So low coronary artery blood flow is also present with a lower mixing point, and this actually refers to the Harlequin syndrome, also the North-South syndrome. In VV ECMO, we're not really protective during cardiac arrest. So when you've got a cardiac arrest and you're on VV ECMO, you still need to do resuscitation like normal, because you have to pump or do compression to get the blood flow into the patient's system. And that's why we say we won't put patients on VV ECMO if they've got a cardiac output problem. It's more volume sensitive, and you need to manage your volume better. So yeah, we actually want our patients in a negative to an equal fluid state. So we tend to dry them out more, give more Lasix, and get rid of the extra volume because it's taxing on the alveoli. It does not rest the heart, so it only rests the lungs. And mixing efficiency of oxygen, what would you like to say there?
It's just your mixing efficiency of oxygenation and recirculation. So you need to keep a good eye on the recirculation, because that's one of the big disadvantages during VV ECMO, because the two cannulas are too close to each other. So there's a slide that we will discuss recirculation in full. yeah, so that is definitely something specifically in VV ECMO that you need to keep an eye out for.
Okay. So venous cannulation sites would be the right and the left femoral vein if it's adult patients. The right internal jugular if it is. So the venous cannulation is always your drainage cannula. Okay, so that will always be in a vein. So if it's an adult patient, we use the right and left femoral vein. If it's babies, we use the right internal jugular to drain from. And the right atrium will be used for drainage if we do central cannulation. So, and that's more when you are busy with bypass surgery. So you won't really see central cannulation in ECMO if it's done in the ED setup, because we use percutaneous insertion sites, and this is more for your patients that can't come off bypass and need to go to the ICU, and then we put them on ECMO. So the arterial cannulation sites will always be it could either be the right or the left femoral artery, so that we can get into the aorta. And we use the carotid arteries to return back for neonates, especially the right side. We can also use the axillary artery, and the aorta will be used pre-subclavian vein or pre-subclavian artery to return back into. So if you have to do a central cannulation and we return into the aorta, it would be just before the subclavian arteries in the aortic arch that we will return to. And then you will see that the flow will be in the normal series, not like we do retrograde flow in ECMO. Okay. Then the next slide. Okay, this is just to show you what the difference is between central cannulation. So if you look at the first picture, the left one, you will see that's central cannulation. So if the patient can't come off bypass, then we will directly connect the ECMO cannulas to the central cannulas in the patient. And the patient will come to the ICU with an open chest. And they will be re-looked at every day or every second day and go back to theatre to be flushed and cleaned and everything else, and then closed up. So what you will see is the drainage cannula will then be it will be from the internal jugular. We will drain. That's connected to the superior vena cava, and then we will replace it into the aortic arch just before the subclavian arteries. If you look at the peripheral cannulation on the right side, this is what you will see. Sometimes you use the same site for both of the cannulas. So it would look, so you'll have the venous one draining out of the inferior vena cava, and the return cannula will be connected to the femoral artery and going up into the aorta. They can also be on different legs. This is not yes, Annie, you can say something. Annie, are you there? Okay. All right. So if you see this, sometimes this is the only place that we can cannulate. We really don't want all the cannulas to be at the same spot. But if there's calcification on the one side, then you will see this. And when we get to the placement of the cannulas, I'll go into why it's important that we are sure that we're in the right places and we don't prick some of these areas, because otherwise you can have bleeding under the skin. Okay, so that's just one of the ways that you can cannulate peripheral. And the other thing that's important is if you cannulate and you hand over to the nursing staff in the ICU, you have to tell them that you're busy with VV or VA ECMO, because if you look at that second picture, the peripheral cannulation, this could either be VV or VA. You won't know it if you don't know it. So when you hand over to the people where you are delivering the patient to, you have to tell them that you're busy with VV or VA, because you can handle the patient differently when it gets to a rest situation or where the pump stops. You have to determine if it's blood flow or gas flow that you're busy with in order for you to help your patient first. Okay. Then if you look at pediatric cannulation, we always use the neck veins and arteries because they're not fully developed in the groin area. So as soon as they start walking, then they get better developed there, and then you can use the groin vessels. But before that, we normally, if we do VA ECMO, we will drain from the inferior vena cava, and we will return back into the right carotid artery, and that's how it works. And then on the VV side, we normally use a Avalon cannula, which is a single cannula with a dual lumen on the outside, and that's how we do VV ECMO in the babies. Okay, so the North-South Syndrome happens when you're on VA ECMO initially, and as we've discussed previously, we use the cardiac output to determine the percentage of blood flow that we want to manage initially. So we'll start on around about 80% of the total blood flow of the patient when we go on to VA ECMO. And then as soon as the heart gets better, we will have to reduce this. If we don't reduce the blood flow on the machine in VA ECMO, and the native heart's getting better and pumping better, and they overlap, then we get a situation where we deprive the head and the shoulders from any oxygenated blood. And we call that the North-South Syndrome, also the Harlequin syndrome. And it's important for you to be on the lookout for this because we're always trying to protect the patient's brain. So we need to have enough oxygen going to the brain. And if this happens, then we have to reduce the flow from our side because the patient's own heart's getting better. And as soon as you get to a point where you're almost only flowing 1 liter, which is very little and not really adequately doing ECMO or cardiac assist anymore, then and you check your blood gases and you see that your blood gases are still not there and you still need some oxygenation to go there. Then we normally, if you look at the picture, as it's returning back into the aorta here, this is normal VA. So we'll drain from the inferior vena cava and we will return back into the femoral artery into the aorta. And now we reduce our flow here because the heart is getting better. And we are at a very low flow. And now we see our lungs are not well. Then we will cut into the return line and take another line and a cannula and place another cannula into the inferior, into the internal jugular that goes into the superior vena cava. And that is just to keep some more oxygen into the lungs. So that's what we will call VAV ECMO, and that's just one of the other configurations that you can use as your patient is getting better. Okay. And the North-South Syndrome is the only thing that will happen in VA ECMO that you have to look out for. Okay, so Lizelle is going to tell us what's going on here.
Yes. So over the weekend, we actually got straight into experiencing something like this, a patient that had left ventricle distension because of an acute septic story, myocarditis and things that is going on with her. And it was so beautiful to see. I just wish I could have get you the sonar that we could show you exactly how it looked like. The left ventricle didn't want to contract at all. And obviously she had to go on to VA ECMO. And it was just unbelievable to see the moment that they placed in that LV vent. It was unbelievable, and offloading the left ventricle. Now, how we would do that is, so normally the cardiothoracic surgeon will put in a LV vent through the pulmonary vein, straight through the left atrium into the left ventricle, and then connect that cannula to the drainage line, to the blue line of the ECMO machine. And by that way, we are able to drain a bit more out of the left ventricle. The moment that they started offloading that left ventricle, you could see the contractility and everything just happened much, much, much better for this patient. We had to flow on very high flows on her because, I mean, obviously her left ventricle is not working because of the infection. And the moment we start decreasing on the flow on the ECMO machine, not enough oxygen was supplied to her. So they were really in a catch-22. And that's when they decided to use this type of left ventricle offloading. And I'm sure that the feedback, if we get feedback today, that we will already be much, much, much better. And then also the other product that you can use to offload the left ventricle is the aortic balloon pump. So if you have place to add a balloon pump to the circuit, then it would actually be good. It will help, and it will also help with the pulsatility, because in VA ECMO you take away that pulsatile flow, not completely, but you take it away from the patient, and our bodies need that pulse, our organs. So if we add something like an intra-aortic balloon pump, that will also add to the perfusion of our organs. So that is something to keep in mind. Please, it's manage it and know what you're looking for, and I can promise you that if that's the way you need to go. The picture that you see there, there's a lot of ways that you can do it. But for the cases that we have done so far, we find that that is the easiest, the quickest, the safest way to offload the left ventricle. Good. Any questions on this? Okay.
Okay, so how do you choose the right cannula? So this is patient dependent. And remember last week we said you had to work out your cardiac output. Yeah, and there's a very fancy way of doing it according to perfusion, which is the square root of the height in centimeters and the weight in kilograms times 3,600. And then you divide, you divide it by 3,600 and you times it by 2.4. So it's your body surface area times 2.4, and that will give you a cardiac output. So whenever someone phones us to put a patient on ECMO, we'll ask what they weigh and what the height is. We'll do our calculation. The easy way is to take around about 70 moles per kilogram for adults, 90 moles per kilogram for children that are walking up to 12. And for babies, we use around about 120 milliliters per kilogram. And now you've got your cardiac output, which is your liters per minute that your heart is pumping. And according to that, we decide what we're going to use. So 60 to 70% of that total flow would be required for VV ECMO and up to 80% for VA ECMO. So VV ECMO is only for the lungs, and we are only oxygenating the lungs and getting rid of the CO2, where VA is supporting the heart and the lungs. Okay, so we've got a grid that we use, and this is in our little book. It's a flow chart. So say, for instance, we've worked out that our cardiac output is 4 liters per minute. So then you will see on the side there, it says arterial cannulation and the 4 liters here. So that's the total flow that you've worked out. So for that arterial cannula, you need a 17. And if you go down with the grid, this is our venous cannulas, and you look for your 4 liters, then you will require a 21 French for the venous catheter. So the venous cannula is always bigger than the arterial one. It's around about, there's about 2 to 3 French sizes difference between the two. And it's because we have to drain a lot of blood per minute, anything from 2 to 4 liters per minute out of the patient when we drain. So we need a bigger cannula for that with more holes. And then the return cannula is a smaller cannula with less holes, so that we've got a higher pressure to give off to the patient, because the pressure on our side must be higher than in the patient. So that's just how it works. If you choose your cannula sizes wrong, then you're not going to have a very nice ECMO. Okay, so it needs to be configured like that in order for us to flow correctly, so that our pressures on the machine doesn't get too high, and we're not going to have such a lot of damage on the patient's blood as well. And also don't choose a too big cannula. The cannula must only obstruct about 2/3 of the complete circumference of this vessel. So in order for you to start your ECMO, you need to do your cardiac output, and then you're going to choose your cannulas. You're going to have maybe a size bigger or smaller to go with. And then when you get there, you need a sonar machine to measure the width of your vessel. On the boxes where the cannulas are placed in, the actual diameter of the cannulas is on there as well. So together with this grid and what you see on your sonar according to the patient's vascular structure, you decide what cannula you're going to put in there. If you have a too big cannula, remember we want to have our patients as dry as possible. So we will always reduce the fluid as much as we can, because normally they've got fluid in the extras in the third space. So as soon as you go onto ECMO, we actually reduce the cardiac output by, say for instance, you lose a liter per day, it's more or less a kilogram, so then your cardiac output also changes. And then your vascular bed shrinks. So then if you dry your patient too much, then your cannula is going to be uncomfortable in there. You're going to have a lot of tagging on the outside. And then we're going to give too much volume to loosen that up. So rather choose a smaller cannula, or not a too big one that's going to obstruct the whole area, so that you've got a smooth ECMO case going on. Okay. And then I just want to look at the bottom one. You'll see there's the Avalons are on there as well. So it will give you an idea of how much your maximum flow would be. So if you look at the, say for instance, the 27 French there, you can flow up to 4 liters. So keep this in mind, because Avalons are only for VV ECMO. But if you've got a very big patient, the 4 liters might not be adequate for him. So then you'll have to opt for a 31. If you have 31s, then you can go up to 5.5. But we sometimes have patients that's that's COVID patients or H1N1 patients or whatever, that's up to 120 kilograms, 200. We've seen a lot of big people. So then you'll need single cannulas for VV ECMO. Yes. Okay, good. Next slide. So this is just to show you what the cannulas look like. So you'll see on the arterial cannulas, they're smaller. They're normally smaller than your venous cannula. They're also shorter, and they've only got a hole in the distal part and then 2 holes on the side. They are wire reinforced. There's a soft part here that you can actually clamp, and I'll show you just now when we go into the practical part. And it's got a little tap as well, and this is for your distal perfusion cannula to hook onto. And yeah, so the lengths we have is a 15 and a 23. And they go up to a, what was it? To a 23 French. Yeah. And then the drainage cannula is a bigger, longer cannula. It's also wire reinforced. And you'll see the holes start from here. There's a whole set of holes here to drain all that blood at one time. And we also have a soft part where we can clamp, and they go up to a 29 French, and the lengths are 38 and a 55 centimeters. So it all depends on how you want to do it and where your insertion sites are of the lengths and the sizes you're going to choose. Okay. Then this is our Avalon cannula. This is only for VV ECMO. It's very important that you put this cannula in under continuous imaging, and you'll see why just now when we show you the video. There's a few set of holes. So there's top holes, a middle hole, and bottom holes, and they need to be placed in the right places. So the top holes must be in the superior vena cava, and the bottom holes must be in the inferior vena cava, and the middle hole must be just in the right atrium, almost at the tricuspid valve. So if these things aren't placed correctly, then you're going to have recirculation, and you're not going to adequately be able to flow your patient and get him better. Okay. Then it's important to suture your cannulas in the right place. So when I go to the practical side just now, I'll show you. Okay. So here's our little video. Yeah. Well, okay. Okay, so this is where they insert it. They're just telling you that it's wire reinforced.
Its patented dual lumen design incorporates
Antoinette, I think you should talk through it because we're not hearing sound.
Okay, so here we go. Okay, so you can see in the top and the bottom parts there, we've got holes, distal place. The catheter body is also wire reinforced. On the inside of this catheter, there's two lumens. So the one lumen will mouth out at the middle hole, and the other one will be connected to the bottom and top holes. It's very important that you get your guide wire right. It must go from the superior vena cava to the inferior vena cava, and that's very important. Otherwise, you're going to have a miss happening. This is how we insert it over the guide wire. And then you will see that the middle hole will be here, placed just almost at the tricuspid. So it's very important that you see that on the imaging. And that's how you're going to secure it. So we'll take the unoxygenated blood from the bottom and the top. Then it comes back via that middle hole into the patient. And that's how we actually get the oxygenated blood back. And then it jumps through the tricuspid and up into the pulmonary artery. And that's our Avalon cannula. Okay, perfect. Are you happy with that?
Yeah, but it's nice because it's a single hole cannula. It's a single incision site cannula. So you can mobilize the patient, and with ECMO, that is something that we want to do as soon as possible. Wake them up and mobilize them as soon as possible. So the Avalon cannula will be perfect for something like that.
Okay, so this is our distal perfusion cannula. This is mandatory with VA ECMO. The reason for that is we need to bypass some of this blood into the leg on the side that you've placed the return cannula in. So remember, on VA ECMO, the return cannula is directly into an artery. And if you flow back with about 4 to 5 liters, you're taking all the blood flow away from the leg. So we need to get some of that blood back into the leg. So you will get a 6 or a 7 French sheath from the cath lab, a normal sheath. And in that same artery that you are flowing upwards into the aorta, you'll put your distal perfusion cannula. And then that distal perfusion cannula, it's got a side arm. So what will happen is this is your venous drainage cannula. And then it will go through the system and get oxygenated. The oxygenated blood will come back in the femoral artery. And in that same artery, you put your distal perfusion cannula going downwards. So this one's going upwards towards the patient's head, and that one is going downwards towards the patient's foot. So as the blood comes back at a very high pressure, some of that blood gets pushed into the side port of the sheath, and then it gets pushed down into the leg, and that's how we perfuse the foot. If you don't put this up, and when you start your cannulation and it is via ECMO, you're not going to get it in after you went onto ECMO because the vessels collapse. Even if you do a cut down, it's very difficult. So I suggest that you put in your distal perfusion cannula, then your return cannula and your venous cannula at the same time before you go onto ECMO. Otherwise, you're not going to get it in. And it's really important. If you didn't put it in, you will see a white foot within even sooner. And you can have cell death there, gangrene, and all the rest. And we have had amputations due to no distal perfusion cannulas initially when we started with all this. Okay. All right. So recirculation. So what is recirculation? This can only happen in VV ECMO. So when your cannulas are placed too close to one another, so the venous cannula is supposed to be situated in the hepatic junction, just below the heart. So if you're going to do your x-rays and see where your cannulas are at, your venous cannula's tip must be just below the heart in the hepatic area. And then if it is too high up and gets too close to your arterial cannula, what will happen? How will you know that your patient is recirculating? Who can tell me? At a glance. So now you're transporting your patient and you've moved him a little bit, how will you immediately know that you're busy with recirculation? Who would wants to take a chance? What will you see? So if you look at the lines on the outside that you so dearly protect, that mustn't pull out and everything, if you check them, the one that's collecting the venous unoxygenated blood will be dark red. The one that's returning the oxygenated blood will be bright red. If you see that both those lines on the outside are bright red, then you must suspect that you are busy with recirculation. The other thing that you will see is if you do a venous gas, and if you're on our machines, you'll see the SVO2 constantly. The SVO2 will be much higher than your SaO2. And that's not supposed to happen. I mean, that's impossible. It will only happen when you've got recirculation. So if you look at your picture, if this cannula moves up towards the return cannula, what will happen? So the oxygenated blood comes back from here, then the venous one is sucking it away. And if they are close to one another, the oxygenated blood only stays in the circuit outside the body. It doesn't get time to get into the lungs like normal ECMO is supposed to happen. So how will we correct this now? The only way that you can correct it, if you are busy with transport, you can try and increase your flow on your ECMO device just for a little while, but you should actually move this one out and that one out as well. Okay, so you can't really manage it with these type of things because you're going to have oxygenated blood only circulating in the patient, and we need to correct that as soon as possible. Okay. Nee? All right, so now the next one. So this is what we need to insert the cannulas. You'll need a PIC 100 or a PIC 150. That just say PIC stands for percutaneous insertion kit. The 100 is the length of your guide wire. So we've got 100 centimeter guide wires and 150 centimeter guide wires. You're also going to have an 18 gauge needle in there. You're going to have a mini scalpel. And you're going to have a set of 4 dilators. We also have extra dilators. And then you also can you just mute your thingies? Then we have a scalpel in there. We will actually make the insertion site a little bit bigger. And yeah, so that's our insertion kit. If you need extra guide wires and you are busy traveling, you'll see that this is a 0.038 guide wire. You can also use a 0.035 guide wire, which is a stainless steel one or a super stiff one. Be sure that if you use any stiff guide wires that you have imaging. Stiff guide wires can also make a lot of damage. Okay, so that's just the insertion kit. Okay, so what do you require for cannulation? In VA ECMO, we require imaging always, and you can use a sonar. In both of them, you're going to need imaging, sonar, TE, or fluoroscopy. We advise that you use these because it makes your insertion much easier. You need a membrane, you need your insertion set and your dilators. You need 4 metal clamps. Because the clamps that we have on our packs are plastic, they will save a little bit, but they're not going to save it completely if you have a problem there. Heparin saline flush, you need a bubble syringe to do a bubble-free connection, and you need a cut-down set. You need at least 4 silk sutures. We use silk instead of nylon, because if you use the nylon ones, it can actually cut through the cannulas, and then you have another problem. You need a 6 or a 7 French sheath, and that's only for VA ECMO when you need to do the distal perfusion cannula, and you need a male-male connector to connect the sheath to that arterial cannula's little port on the side. Then you need ioband dressings. That's the ones that we most frequently use, and you're going to cover the whole area. And you need a crepe bandage for the return cannula just to secure it around the head. If we look at VV ECMO, if you're going to use an Avalon cannula, you definitely have to do that in a cath lab situation or with a C-arm where you can really see what you are busy with. Then you also need a membrane insertion kit dilated, and the rest is basically the same. Okay, and then yeah, so this is things that you will be needing to do a cannulation. Okay. Then cannulation steps. Okay, so I'm gonna describe everything to you now, and then we will go through this just after that. Okay, good morning, everyone. I'm happy to be here today. I just want to get everything here. So first of all, we've got two cannulas, one for draining, one for return. So this is your venous ones and your arterial ones, and you can see they're big. So as nice as cannulation sounds, it can also be very dangerous. The venous cannula goes up to 29 French, and this is only a 23. So it's actually you get much bigger ones. So if you're not going to do your cannulation slowly and meticulously, you are going to run into problems. So first of all, and this is our Avalon cannula, and this is a 27 French. Always go in via the jugular on the right. Not from the temple side, not from the subclavian side, but from this side. Then look at the insertion kits. What that looks like. You're going to connect it's an 18 gauge needle where you're going to connect it to your syringe. You're going to go into your vessel. You're going to pull back, see if you've got dark red blood or bright red blood. If you've allocated your vessel, you're going to take the syringe off. You're going to use your guide wire, and you're going to go through the. Today is not a good day. Sorry. So you're going to go through your syringe with your guide wire into the vessel. Okay. And if you use your syringe, now you're going to start dilating. As soon as you dilate.
Sorry, Antoinette, I'm sorry to stop you, but the video is not showing. Can you restart your video?
Yes.
And can you also talk louder at the video? And if I can ask the participants to please check that they're all on mute.
Can you hear us?
Can you see us now?
No? Unless it's just me. Can anyone see Antoinette?
Hi, Mandy. I think it's just you. She's clear on my screen.
Okay, perfect. All right, go ahead, Antoinette.
Okay, we're going to increase the volume.
I think you also can't see her.
Okay.
I also can see her.
We also cannot see the union.
Hello guys, just move your screen. You can slide your screen at the bottom.
Who was that giving us advice? Give it again.
Hi, Mandy, it's Ernest. Just move your screen at the bottom.
What do you mean move your screen at the bottom, Ernest?
So you can see at the bottom, it scrolls to the side, and then you can see the lady talking.
Okay.
And pin it, yes, yeah. If you can't see us,
You got terrible feedback. Giselle, you can't have your computer and intranets on.
No, it's okay.
better now.
Yeah, much better.
If you click on it on the right click and just pin the video, then you will see until you click it. Yeah,
Getting tight.
There's at the top of your screen or at the bottom of your screen, there's like a blue arrow. And if you click on Lizelle's video, and everyone else can switch off their videos, please. Nati and Smith, Chabalala, and Annie, if you can switch your videos off, please. Uriel, switch yours off. Paletza, Annie Skolts, everybody else. If you can just switch off your videos, please. Okay, Lizelle, continue.
I think one of you may need to mute your speaker if there's two computers on.
Yeah, thanks everyone. We'll deal with the problems now. Can everybody just go on mute so that we can get everything under control?
Hello?
Hello?
Can you hear us now?
Yes, and see you. Thank you.
Okay, fantastic. Is it better?
Go quickly before it all goes away.
Okay. Okay, so first of all, you will get...
Talk loud.
Huh?
Praat hard. Talk loud.
Okay, so first of all, you will locate your vessel. Let me somewhere sit here. Nee. And you will go in not perpendicular at the 30 or 40 degree angle into the vessel. Pull back, get your dark red or your bright red blood back, and then you will disconnect your needle. Okay, into the vessel, like so. And now you've got full dilators, step-up dilators in the back. And after the full step-up dilators, you even have bigger step-up dilators, like these ones. So now, okay, and then you're going to start dilating over your guide wire, the smallest one up to the biggest one. And you can see these ones look like knitting needles. They're very big. And they're very dangerous, and they can cause a lot of damage if you don't do it in a controlled fashion. So what you're going to do with your dilator, you see that they're very long. And I'm a big person, so I can go from my front to my back. And it's important that we don't hide the whole dilator into the patient's body. If you don't have imaging, it's okay if you can see what you're doing. But if it's a blind insertion, I recommend that you only go halfway, because nobody's fat is thicker than this. And you just need to get into the vessel. If you're going to not know where you're going, you can easily perforate the vessel on this side. So now you're going to dilate. We're now at the fourth one. As you go down, make sure that you don't go perpendicular. You have to go the fairly low angle, like 30 degrees at least, with the patient's body and the anatomy. If you go perpendicular, you are sure to bend the guide wire backwards. And if you bend the guide wire backwards, it's going to kink. And then when we start dilating, you must remember, we're giving our heparin into the patient now. So we normally give anything from 3 to 5,000 units into the patient immediately to get the blood thin so that we can go into ECMO. So now it's bent backwards. Now you start pulling. If you're gonna keep on pulling, this is gonna break off. And we've been there. Then this part merges down. So now you've got another situation. We need to have the vascular surgeon come and do a cut down. And there's a lot of bleeding and all kinds of nonsense. So please, if you have resistance, come out with the whole business and start over. Okay, before you break it, and there's a lot of things gonna happen. So now you okay. If you've dilated the last one, you come out. Then you go over the wire with your cannula, like so. So there's a little hole in here. You can flush your, you can actually wet it with saline or your heparin flush. So you go over the guide wire. So if you bend your guide wire, be sure that you have an extra set of guide wires that you can do your thing. You'll go over. You'll use little small ways to get it in. Don't push it from the back. You can see that it's a big cannula. As soon as you've pushed it up to the hepatic junction here, and remember this part is also going to show in the x-rays. It's quite a long part. So see that you can see the tip of the cannula, otherwise it's going to be too low. The real tip and not only your stylet. Then you're going to pull the stylet out together with the guide wire, and then your assistant is going to clamp, or you are going to clamp on the soft part in the cannula. Okay, so be sure you clamp on the soft part, okay? And all of the cannulas have a soft part, not on the metal reinforced part, because you're going to kink it and you're not going to have any good flows. And it's metal reinforced, so that when it gets hot in the body, it doesn't collapse and you still have good flow. So it must be clamped here. Don't clamp it here because you're going to use metal clamps and that can crack my connector. So clamp it here. So you put in your venous one first. Then we're going to insert our return one either into the superior vena cava or in one of the femoral arteries to go into the aorta. So this is the, oh, actually this is my aorta, yeah. Okay, so the same will happen. So if we put in our distal perfusion cannula, understand, your cannula will be in here, and in the same artery, you're actually going to put in your sheath. Then the sheath is going to be connected to the side port here with your male connector, so that all the high pressure blood that's coming back, some of that will be pushed into the side port and go into here. From here, it will go down into the side port and down into the leg, so that you have perfusion to your foot taking place. It's about 200 mils that you supply the foot with. The other thing is, this is now our abalone, okay? So with the abalone, it's very important that your guide wire goes down from the superior vena cava down to the inferior vena cava. And you need to see this on the imaging. If you don't see this part down here, and you're going to do it blindly, the way of least resistance for this guide wire is to go into the ventricle. And when you're going to start dilating, and you're going to do it blindly, I can assure you that you are going to puncture the ventricle. Okay. And then how long have you got to save the patient? Less than 2 minutes. Because if you've got such a big hole and now you're going to start resuscitating, giving blood and fluids and all the rest and inotropes, it's not gonna save the day. You must keep your eye on the monitor. Check your blood pressure. If you see it drops, there's a problem. Okay. And it's very important that you see that this guide wire goes down. All right. Then we have to connect. So if we connect, we are going to use, you need to make a heparin and saline flush, and then we're going to connect to the consumable. So in the consumable, I don't know if you can see, there's 2 places we can put clamps on. So this is our sterile field, and when we get to the practical part, we will show you how it works. So you're going to clamp on the 2 clamp where the 2 clamping places are, and you need to cut off before the connectors that goes to your priming bag. So our priming bag would have been connected to this side. Okay, so you have to cut this off so the priming bag can fall away, and then you only have remaining part going to the membrane. Okay, because this is the part that's going to the patient. Right. So you will clamp it there, we'll cut it off, and for all intents and purposes, this is now our cut off line, and we're going to have 2 of them, one for the return cannula and one for the venous side, and we've got our 2 cannulas placed in already. Okay, so if it's in the patient, like so, and like that, we will do a bubble-free connection. So it's very important, I'm going to let this one drop, that you, if the surgeon is handling these 2 lines, or the one who's placing the cannulas, you must have a firm grip on it. So what you do is, above the clamps, you will fill it up with heparin saline, and on the other one, until it's full. Oh, okay. Sorry, we just want to show you properly. You see, that's why you need metal clamps. Okay, so we fill it up again. So as soon as they both fold, your assistant is going to fill, and you're going to do a bubble-free connection. Okay, that's how you get a bubble-free connection. You'll push your cannula or your tube over up to the connector's little reach here, and then make sure you cable tie it in the middle. Okay, it's important to cable tie it because as soon as these things kink, wherever you're transporting the patient, the pressure gets very high on the lines and it can easily jump off. Okay, so for any transport situation, you see all these clamps, these 4 with each patient's pack, you need to take them with, because if anything happens and the patients discannulate or decannulation take place, you need to clamp the lines as quick as possible. Okay, you only have 2 minutes, because remember, we're not fully flowing the patient is 4 liters, we're doing half of it. So in 2 minutes time, you will be draining all the blood out of the patient if you don't stop it. It's important to clamp the red one first, then the blue one, and then you go to the machine and you turn down your revolutions to 0. You put pressure on that area and you must give the patient fluid or whatever you're going to do to save the day. Okay. As nice as ECMO is, it is also very dangerous, and we want you to have a safe practice going on. So I think for cannulation, that is it for today.
Perennisation before you go on.
Yeah, I did say something.
Okay. Then I think.
What's the next?
And no, ons moet nou op ECMO gaan basies.
Okay.
We need to go.
So now we're ready to go on to ECMO, and I actually just want to know if there's any questions, because let's quickly go through this. So we secured the vessels. Nee? So we secured the vessels. You chose your vessels where you want to go in. You got the cannulas in via the insertion kit. You anticoagulated the patient when you started dilating. And actually, as soon as the guide wire goes in, when we normally anticoagulate the patient itself, then you insert the cannulas in the vessels. They all will be clamped. That we sometimes only fixate the cannulas after we are sure that they're in the right place. So we will clamp and go onto ECMO and then fixate the cannulas. And it's important that you fixate them in a lot of places. You'll see on the cannula itself, there's a little reach, so that's your suture reach. And you can suture them on here and then also around here. If it's an Avalon cannula, we normally suture them a lot of places. It's important that the shorter or the skew little arm that's returning the oxygenated blood is more medial and the other one is lateral. If this cannula is turned in this way, then the bigger hole will actually suck against the vessel wall and there will be no good flow. So you need to secure it in the right place. And then we suture it everywhere on the edge, everywhere. Okay? And then you're also going to put the bandage around it so it doesn't pull out. And then we connect it to the ECMO system. And we get flow. We do a blood gas and the ACT to see where we are at. And then we prepare for the transport. And that's it for today, I think. Yeah. Is there any questions?
There is a question from Bonita Fenta.
Yeah.
The chat has been disabled. Bonita, do you want to unmute yourself?
Hello, it's Jamie from Hill. So I've got 3 questions. The first question is, you said with that patient that you had with the left ventricle not contracting, how much time do you have to put ECMO in for it to be effective? That's my first question.
Okay, the patient was admitted to Unitas, I think, about 8 hours before.
Yeah.
And then they put her on ECMO, and then they did a sonar to see that there was no ventricle function. And then within the next 8 hours, from the night to the morning, there was actually a little bit more function. And then they decided to do the the venting.
Yes, yeah, because they were still on massive inotropes, as I understood it. And I mean, that's the aim that we want to do with ECMO. We want to get the heart contracting again. So if we don't have a contracting heart, we are not getting it better. We are not achieving our purpose. So they went, I think it was less than 24 hours. They decided to go in with the left ventricle cannula. So because we need to get that ventricle contracting and working as normal as soon as possible. So I mean, so that's where the indications for ECMO comes in. Left ventricle didn't want to pump, so obviously we were on massive high amounts of inotropes. So then they opted for ECMO because the heart is not pumping properly, now oxygen is going to the rest of the body. So they decided to go on to VA ECMO because there was nothing. That ventricle didn't even vibrate or anything. And then after going on to ECMO, they sorted out the gases actually started looking better. Everything was looking better except for the sonar. And then that's when they decided to do the left ventricle cannulation. And I promise you, it was like within 15 minutes, you could see that ventricle contracting, everything went well. So I'm sure now, I think if we talk to Dr. Marlies, she would obviously, Dr. Marlies, you're not on the call. Not on the, if Dr. Marlies is not here, then we will, next week we can give you feedback on that one as well. So yeah, it was just amazing to see that a small thing like that, because if they continue to go on with that high flows, we needed to give the high flows on the ECMO machine, otherwise we will not be able to oxygenate. Yeah. And like Antoinette mentioned, it's important to get oxygen to the brain, but now because we were flowing too high, we were damaging other parts of the body. Yeah. So we needed to get that extra cannula, extra drainage. We need to do that for the patient.
And this is a very acute myocarditis.
Yes.
Yeah.
Yeah.
So I think if she didn't intervene when she did, then the patient would have been here now.
Yes.
Yeah. Okay.
Did we answer?
Are there any other questions?
Yeah, I've got another 2 questions. Then, what's your candidate criteria for ECMO? And then the other thing is, I read something about ECPR.
Yeah, okay, that's still coming.
Okay, so the criteria for patients, well, for COVID, they say the cutoff age is about 55. And I must tell you that the sooner we get them much earlier now, so the outcomes are better. So you need to, if the patient has any kind of cancer, we don't put them on. If we have a failing aortic valve, then we don't put them on, and we also don't put patients on with aortic aneurysms.
Yeah.
So that's basically it. Otherwise, we
and ventilation.
Yeah,
not
and
more than 7 days.
Yes, and also not more than 3 organ failures, because as soon as we go into ECMO, it's the heart and the lungs, sometimes the kidneys as well. So look at all the other organs. If they're already in failure, then we don't put them on ECMO. Yeah.
So that's basically the can I say I want to say contraindications, but that's like the relative contraindications where we will not look at patients with ECMO. But then on the indication side, we will, the lungs are not oxygenating, or, they are hypoxic, they are hypercapnic. Patients that got low cardiac outputs and you're already on massive amounts of adrenaline and inotropes. But all the conditions must be reversible. You must be able to get them back.
Or the ECMO must be a bridge to something, a bridge from the theatre bed to the ICU, or it must be a bridge from lung and heart failure to receiving new organs. So we don't put failure patients on if we're not sure that they are going to receive the organs on the other side. The other thing that we don't put on is patients who had a long arrest period. So, and we've got dilated pupils and stuff, you don't think that you've got any brain function. So we don't put patients with brain hemorrhage. It's also like a relative one, because we sometimes do have those. But I mean, that's also kind of a contraindication, because it can seriously go in a different direction and not in a good direction. So yeah, that's things that you have to look at. Yeah.
I see our time is up. So if there's one last question, if there's any, otherwise then we will say goodbye for today.
Are you there?
Yeah, we here. Are there any other questions? I see the chat is disabled and I've been in to try and undisable it. So if you can just, I don't know why it's disabled. Maybe Lizelle and them on that side disabled the chat, seeing as though they are co-hosts.
Yeah, nothing. I don't see anything here on our side.
But it is disabled. So are there any other questions?
Yeah, sorry, it's Sister Anna at the union. I just want to find out if you're going to send us the notes again like you did last week.
Yes, Sister Anna, definitely.
Thank you.
Good.
Is there anything else? Nothing, guys? Okay, I'm glad I survived the second lecture. Thank you very much, Antoinette and Lizelle. And we'll see you next week. And we had almost 93 people on. It's gone down to 78. I'm sure they got a bit bored. No, I'm only joking. Thanks very much. Bye-bye.
Thank you. Have a good day.
Bye-bye.
Bye.
A little bit bored.
Okay,